Intellectual disability, also called intellectual development disorder or general learning disability, and formerly known as mental retardation, is a generalized neurodevelopmental disorder characterized by significantly impaired intellectual and adaptive functioning. It is defined by an IQ score below 70 in addition to deficits in two or more adaptive behaviors that affect everyday, general living, once focused almost entirely on cognition. The definition now includes both a component relating to mental functioning and one relating to individuals' functional skills in their environments. As a result of this focus on the person's abilities in practice, a person with an unusually low IQ may not be considered intellectually disabled. Intellectual disability is subdivided into syndromic intellectual disability, in which intellectual deficits associated with other medical and behavioral signs and symptoms are present, and non-syndromic intellectual disability, in which intellectual deficits appear without other abnormalities. Down syndrome and Fragile X syndrome. Examples of syndromic intellectual disabilities. Intellectual disability affects about 2 to 3% of the general population. 75 to 90% of the affected people have mild intellectual disability. Non-syndromic or idiopathic cases accounts for 30 to 50% of cases. About a quarter of cases are caused by a genetic disorder. Cases of unknown cause affect about 95 million people as of 2013. The terms used for this condition are subject to a process called the euphemism treadmill. This means that whatever term is chosen for this condition, it eventually becomes perceived as an insult. The terms mental retardation and mentally retarded were invented in the middle of the 20th century to replace the previous set of terms, which were deemed to have become offensive. The term intellectual disability is now preferred by most advocates and researchers in most English-speaking countries. As of 2015 update, the term mental retardation is still used by the World Health Organization in the ICD-10 codes, which have a section titled Mental Retardation. In the next revision, the ICD-11 is expected to replace the term mental retardation with either intellectual disability or intellectual developmental disorder, which the DSM-5 already uses. Because of its specificity and lack of confusion with other conditions, the term mental retardation is still sometimes used in professional medical settings around the world, such as formal scientific research and health insurance paperwork. Signs and symptoms. The signs and symptoms of intellectual disability are all behavioral. Most people with intellectual disability do not look like they are afflicted with such, especially if the disability is caused by environmental factors such as malnutrition or lead poisoning. The so-called typical appearance ascribed to people with intellectual disability is only present in a minority of cases, all of which are syndromic. Children with intellectual disability may learn to sit up, to crawl, or to walk later than other children, or they may learn to talk later. Both adults and children with intellectual disability may also exhibit some or all of the following characteristics: delays in oral language development, deficits in memory skills, difficulty learning social rules, difficulty with problem-solving skills, delays in the development of adaptive behaviors such as self-help or self-care skills, lack of social inhibitors. Children with intellectual disability learn more slowly than a typical child. Children may take longer to learn language, develop social skills, and take care of their personal needs, such as dressing or eating. Learning will take them longer, require more repetition, and skills may need to be adapted to their learning levels. Nevertheless, virtually every child is able to learn, develop and become a participating member of the community. In early childhood, mild intellectual disability may not be obvious, and may not be identified until children begin school. Even when poor academic performance is recognized, it may take expert assessment to distinguish mild intellectual disability from learning disability or emotional, behavioral disorders. People with mild intellectual disability are capable of learning reading and mathematics skills to approximately the level of a typical child aged 9 to 12. They can learn self-care and practical skills, such as cooking or using the local mass transit system. As individuals with intellectual disability reach adulthood, many learn to live independently and maintain gainful employment. Moderate intellectual disability is nearly always apparent within the first years of life. Speech delays are particularly common signs of moderate ID. People with moderate intellectual disability need considerable supports in school, at home, and in the community in order to participate fully. While their academic potential is limited, they can learn simple health and safety skills and to participate in simple activities. As adults, they may live with their parents, in a supportive group home, or even semi-independently with significant supportive services to help them, for example, manage their finances. As adults, they may work in a sheltered workshop. People with severe or profound intellectual disability need more intensive support and supervision their entire lives. They may learn some activities of daily living. Some require full-time care by an attendant. Cause. Among children, the cause is unknown for 1/3 to 1/2 of cases. Down syndrome, biloccariofacial syndrome, and fetal alcohol spectrum disorders are the three most common inborn causes. However, doctors have found many other causes. The most common are genetic conditions. Sometimes disability is caused by abnormal genes inherited from parents, errors when genes combine, or other reasons. The most prevalent genetic conditions include Down syndrome, Klinefelter's syndrome, Fragile X syndrome, neurofibromatosis, congenital hypothyroidism, Williams syndrome, phenylketonuria, and Prader-Willi syndrome. Other genetic conditions include Phelan-McDermid syndrome, Mowat-Wilson syndrome, genetic ciliopathy, and Sidereus type 10-linked intellectual disability is caused by mutations in the PHF8 gene. In the rarest of cases, abnormalities with the X or Y chromosome may also cause disability. 48, 4X and 49, XXXXX syndrome affect a small number of girls worldwide, while boys may be affected by 47, XYY, 49, XXXXY, or 49, XYYYY. Problems during pregnancy. Intellectual disability can result where the fetus does not develop properly. For example, there may be a problem with the way the fetus's cells divide as it grows. A pregnant person who drinks alcohol or gets an infection like rubella during pregnancy may also have a baby with intellectual disability. Problems at birth. If a baby has problems during labor and birth, such as not getting enough oxygen, he or she may have developmental disability due to brain damage, exposure to certain types of disease or toxins. Diseases like whooping cough, measles, or meningitis can cause intellectual disability if medical care is delayed or inadequate. Exposure to poisons like lead or mercury may also affect mental ability. Iodine deficiency, affecting approximately 2 billion people worldwide, is the leading preventable cause of intellectual disability in areas of the developing world where iodine deficiency is endemic. Iodine deficiency also causes goiter, an enlargement of the thyroid gland. Certain areas of the world due to natural deficiency and governmental inaction are severely affected. India is the most outstanding, with 500 million suffering from deficiency, 54 million from goiter, and 2 million from cretinism. Among other nations affected by iodine deficiency, China and Kazakhstan have instituted widespread iodization programs, whereas, as of 2006, Russia had not. Malnutrition is a common cause of reduced intelligence in parts of the world affected by famine, such as Ethiopia. Absence of the arcuate fasciculus. Diagnosis. According to the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, 3 criteria must be met for a diagnosis of intellectual disability. deficits in general mental abilities, significant limitations in one or more areas of adaptive behavior across multiple environments, and evidence that the limitations became apparent in childhood or adolescence. In general, people with intellectual disability have an IQ below 70. But clinical discretion may be necessary for individuals who have a somewhat higher IQ but severe impairment in adaptive functioning. It is formally diagnosed by an assessment of IQ and adaptive behavior. A third condition requiring onset in childhood is used to distinguish intellectual disability from dementia, such as Alzheimer's disease or due to traumatic brain injuries. Intelligence quotient. The first English language IQ test, the Stanford Binet Intelligence Scales, was adapted from a test battery designed for school placement by Alfred Binet in France. Louis Terman adapted Binet's test and promoted it as a test measuring general intelligence. Terman's test was the first widely used mental test to report scores in intelligence quotient form. Current tests are scored in deviation IQ form, with a performance level by a test taker 2 standard deviations below the median score for the test taker's age group, defined as IQ 70. Until the most recent revision of diagnostic standards, an IQ of 70 or below was a primary factor for intellectual disability diagnosis, and IQ scores were used to categorize degrees of intellectual disability. Since current diagnosis of intellectual disability is not based on IQ scores alone, but must also take into consideration a person's adaptive functioning, the diagnosis is not made rigidly. It encompasses intellectual scores, adaptive functioning scores from an adaptive behavior rating scale based on descriptions of known abilities provided by someone familiar with the person, and also the observations of the assessment examiner, who is able to find out directly from the person what he or she can understand, communicate, and such like. IQ assessment must be based on a current test. This enables diagnosis to avoid the pitfall of the Flynn effect, which is a consequence of changes in population IQ test performance, changing IQ test norms over time. Distinction from other disabilities. Clinically, intellectual disability is a subtype of cognitive deficit or disabilities affecting intellectual abilities, which is a broader concept and includes intellectual deficits that are too mild to properly qualify as intellectual disability, or too specific, or acquired later in life through acquired brain injuries or neurodegenerative diseases like dementia. Cognitive deficits may appear at any age. Developmental disability is any disability that is due to problems with growth and development. This term encompasses many congenital medical conditions that have no mental or intellectual components, although it, too, is sometimes used as a euphemism for intellectual disability. Limitations in more than one area. Adaptive behavior, or adaptive functioning, refers to the skills needed to live independently. To assess adaptive behavior, professionals compared the functional abilities of a child to those of other children of similar age. To measure adaptive behavior, professionals use structured interviews, with which they systematically elicit information about persons' functioning in the community from people who know them well. There are many adaptive behavior scales, and accurate assessment of the quality of someone's adaptive behavior requires clinical judgment as well. Certain skills are important to adaptive behavior, such as daily living skills, such as getting dressed, using the bathroom, and feeding oneself. Communication skills, such as understanding what is said and being able to answer. Social skills with peers, family members, spouses, adults, and others. Management. By most definitions, intellectual disability is more accurately considered a disability rather than a disease. Intellectual disability can be distinguished in many ways from mental illness, such as schizophrenia or depression. Currently, there is no cure for an established disability, though with appropriate support and teaching, most individuals can learn to do many things. There are thousands of agencies around the world that provide assistance for people with developmental disabilities. They include state-run, for-profit, and non-profit, privately run agencies. Within one agency there could be departments that include fully staffed residential homes, day rehabilitation programs that approximate schools, workshops wherein people with disabilities can obtain jobs, programs that assist people with developmental disabilities in obtaining jobs in the community, programs that provide support for people with developmental disabilities who have their own apartments, programs that assist him with raising their children, and many more. There are also many agencies and programs for parents of children with developmental disabilities. Beyond that, there are specific programs that people with developmental disabilities can take part in wherein they learn basic life skills. These goals may take a much longer amount of time for them to accomplish, but the ultimate goal is independence. This may be anything from independence in toothbrushing to an independent residence. People with developmental disabilities learn throughout their lives and can obtain many new skills even late in life with the help of their families, caregivers, clinicians and the people who coordinate the efforts of all of these people. There are 4 broad areas of intervention that allow for active participation from caregivers, community members, clinicians, and of course, the individual with an intellectual disability. These include psychosocial treatments, behavioral treatments, cognitive behavioral treatments, and family-oriented strategies. Psychosocial treatments are intended primarily for children before and during the preschool years, as this is the optimum time for intervention. This early intervention should include encouragement of exploration, mentoring in basic skills, celebration of developmental advances, guided rehearsal and extension of newly acquired skills, protection from harmful displays of disapproval, teasing, or punishment, and exposure to a rich and responsive language environment. A great example of a successful intervention is the Carolina Obesitarian Project that was conducted with over 100 children from low-SES families, beginning in infancy through preschool years. Results indicated that by age 2, the children provided the intervention had higher test scores than control group children, and they remained approximately 5 points higher 10 years after the end of the program. By young adulthood, children from the intervention group had better educational attainment, employment opportunities, and fewer behavioral problems than their control group counterparts. Core components of behavioral treatments include language and social skills acquisition. Typically, one-to-one training is offered in which a therapist uses a shaping procedure in combination with positive reinforcements to help the child pronounce syllables until words are completed, sometimes involving pictures and visual aids. Therapists aim at improving speech capacity so that short sentences about important daily tasks can be effectively communicated by the child. In a similar fashion, older children benefit from this type of training as they learn to sharpen their social skills such as sharing, taking turns, following instruction, and smiling. At the same time, a movement known as social inclusion attempts to increase valuable interactions between children with an intellectual disability and their non-disabled peers. Cognitive behavioral treatments, a combination of the previous 2 treatment types, involves a strategical metastrategical learning technique that teaches children math, language, and other basic skills pertaining to memory and learning. The first goal of the training is to teach the child to be a strategical thinker through making cognitive connections and plans. Then, the therapist teaches the child to be metastrategical by teaching them to discriminate among different tasks and determine which plan or strategy suits each task. Finally, family-oriented strategies delve into empowering the family with the skill set they need to support and encourage their child or children with an intellectual disability. In general, this includes teaching assertiveness skills or behavior management techniques as well as how to ask for help from neighbors, extended family, or daycare staff. As the child ages, parents are then taught how to approach topics such as housing, residential care, employment, and relationships. Although there is no specific medication for intellectual disability, many people with developmental disabilities have further medical complications and may be prescribed several medications. For example, autistic children with developmental delay may be prescribed antipsychotics or mood stabilizers to help with their behavior. Use of psychotropic medications such as benzodiazepines in people with intellectual disability requires monitoring and vigilance, as side effects occur commonly and are often misdiagnosed as behavioral and psychiatric problems. Epidemiology. Intellectual disability affects about 2 to 3% of the general population. 75 to 90% of the affected people have mild intellectual disability. Non-syndromic or idiopathic ID accounts for 30 to 50% of cases. About a quarter of cases are caused by a genetic disorder. Cases of unknown cause affect about 95 million people as of 2013.